Good afternoon, everyone. Thank you for joining us on another Journal Club from the Florida Medical Directors Association. Today, we're going to talk about racial inequities and disparities. And if you're not speaking, I would ask you to mute yourself, please. So, we're going to start the way we normally do with a quick state of the state. And then I'm going to invite our special guest to help me have a conversation around racial disparities and inequities in post-acute long-term care before we open it up to a discussion. So just to go ahead and get started, I wanted to just share with you where we're at as a country. And in looking through the data, if you've been looking at the data or paying attention to ER utilization, hospital utilization, your own practices possibly, or even watching the news, you will know that we are currently seeing less cases. And as of May 25th, we had 25,925 new cases, which was very good news. If we look at what that means about positivity, the 7-day moving average for the United States positivity rate was 4%, which is very remarkable. And if you're here in Florida, our numbers are for the 7-day moving average is 5.21%, which when I looked at the data from our website, our Department of Health, as of Monday, we were coming in at a positivity rate of 3.75% with 1,889 new cases being reported. So that is a really good news. I think it's it's made for a lot of hopefulness around the country. And in part, it is due to the fact that we are seeing more people get vaccinated. So in the past few weeks, we've seen that the Pfizer vaccine was approved for 12-year-olds. And you can see that for the 12-year-olds who are fully vaccinated, in that pool, that population, we're seeing a lot of uptake. The news that broke this morning was that 50% of all adults were vaccinated. And if you've been researching and following along, you'll know that 73.9% of that population that is 65 years of older have been vaccinated as well. In Florida, we, as of May 25th, we had over 8 million people fully vaccinated. So this has been really great news in the last few weeks. We are seeing a correlation, and we know we have a ways to go with some people who are still hesitant. And then there are others who may be completely against the vaccine. And so we do have a ways to go to get to that elusive 70% goal. But today, I want to talk about something a little different, and it is around racial disparities and inequities in post-acute long-term care. As many of you are aware, the anniversary of George Floyd's death was yesterday, May 25th, and there were some ceremonies and things held around Washington and in the Minnesota area, and in other cities and states across the country. And I thought it would be a good time to reflect on what we've seen this year and the conversations that we've had. And I wanted to have Dr. Brette Svensson on because she's such a dynamic and remarkable person. And Brette, if you can introduce yourself, because I want to make sure we do it justice to everyone who's on, I would greatly appreciate it.
Sure, I'd be happy to. Hello, everybody. Thanks so much for letting me join you today. I was very flattered and honored when Diane asked me if I could join today. I was very fortunate to work with Diane and Dr. Fatima last fall for the AMDA Leadership Symposium, where we talked about this topic. So I am an adult gerontology primary care nurse practitioner. I'm based in Marietta, Georgia. I work for a large healthcare company, but we are contracted with local area nursing homes. So I'm actually contracted to be the primary care provider for a single nursing home. So I come to one facility 5 days a week. And of course, I have a medical director, and we have everybody in the entire building. And so we're responsible for the single facility. My medical director also does about 50 other things, though, but I only come here. I have some ties to GAMDA. I've known some folks in GAMDA for a long time, like Perry from Georgia chapter, which probably all of you know. And I've been very active in the GAPNA organization. For those of you who don't know, that's the Gerontological Advanced Practice Nurses Association. It's the longest title in the world. But through being involved with both of those organizations, I've had a lot of great opportunities to meet new people and network and learn a lot of great lessons from people in the gerontology and the geriatrics world. And so I feel very lucky to be here, and I'm very honored. And I hope we just have some really great conversations today. I'm always learning. I mean, my disclaimer is that I have many lessons to learn myself, and so this is not a what's the right answer type of session. It's all about kind of shared experiences and how can we keep conversations going so that we continue to learn more about ourselves and more about each other, and hopefully bit by bit maybe make the world a better place. So thank you so much, Diane.
No problem. Thank you. Thank you for joining us. So I'm going to start off things by just looking at what we've seen during the pandemic with racial disparities. And I wanted to really highlight what we've seen in the nursing facilities. So we know, and what we've seen is that in those facilities where there are more Black or Hispanic residents, we had a higher share of COVID deaths. So, and this data was reported back, started being captured very early. And it was one of those things that hit us in seeing more disparities around COVID. And when we looked at the nursing facilities, we saw that those same proportions. We also saw that the outbreaks were worse in nursing facilities where there were more Black or Hispanic residents. And I think we are all aware of some of the challenges, and this data is not just specific to nursing facilities, but it's really the challenges that we still face with getting certain ethnic groups and certain groups to say that they will be willing to get a vaccination. So we're still tracking that, and we're still very much aware. So when we're looking at inequities and inequalities and disparities in post-acute long-term care, where I was hoping, as Brette mentioned, we just want to have a discussion. We want to look at some cases, and we invite anyone who wants to weigh in to do so, but we want to just talk about what we're seeing and where we're at as an industry, and possibly some of our own personal experiences and journeys. So the first case is the case of finally someone who speaks English. And Brette, I know this case is very familiar to you. I don't know if you want to share it with the group so that we can talk about it.
Sure. Thank you. This was a case that originally I had thought of after actually having some discussions with some of my colleagues here. I've been coming to this facility for over 8 years now, so there are some folks here that I know really well. I know a lot of our nurses very well, a lot of the CNA care partners, but also my social workers, and we have a lot of discussions about these things, and we deal with a lot of this, especially my social service directors. And so when I was asking about, what would be some good examples of cases to talk about where we could kind of help learn, and one of the things we came up with were situations that we see quite often where the patient says to me, well, let me start back from the beginning. My patient population, if it gives you a background, my patient population here in Marietta, Georgia, it tends to be mostly Caucasian, and it tends to be mostly people who have Medicare or Medicaid, but they have some type of insurance. But we also are located in an area that is predominantly not Caucasian in terms of the groups of ethnic backgrounds of people who live here. And so a lot of times what happens in my facility is that I'll go in to meet a new patient, and I don't know what they're expecting. Sometimes I get a comment like, your English is really great, but a lot of times I'll introduce myself. I say, hi, I'm Brette. I'm your nurse practitioner here. It's nice to meet you. How was your weekend or how was your night? And many, many times I will get from the patient, finally, somebody who speaks English. I get that comment a lot more than I would like. And so that's where kind of the beginning of this case started. And Diane, I don't know how far you want me to go with it in terms of like, do you want me to go ahead and talk about some of the kind of reactions and ways we've tried to deal with it, or do you want me to kind of pause?
So I wanted, yeah, let's talk about how it was. So if this was a new patient, I believe, and we were trying to get a sense of who was going to take care of them. Can you walk us through what happened and how do we even get to this quote, this now famous quote that we probably heard in many facilities?
Sure. So I guess to kind of paint the situation a little bit better, or kind of the next steps forward, they say to me the first time, finally, someone who speaks English. And you know, a lot of the staff of my nursing home, the majority of the staff of my nursing home are coming from different backgrounds. Some of them actually come from international backgrounds. So we have people who have immigrated perhaps from countries in Africa, or we have people who have immigrated from, say, Panama, or their family moved here. And so we have a lot of people who probably look very similar in terms of skin tone, but they actually have a very diverse background. And we have a lot of people working here who, to someone who grew up in Georgia and sounds like me, these people sound like these people have an accent that you're not familiar with. And I think a lot of times that's the main source of these types of comments for my facility, is that when they say to me, finally, somebody who speaks English. And, you know, sometimes I laugh it off and I'll say, well, everybody here speaks English. And I think when we dig it out, sometimes I think it is because we have some staff here who have accents and they're speaking English just fine. But especially nowadays, when you have a mask, or when we had the mask and the face shield, a lot of our patients have a difficult time understanding sometimes these accents. Perhaps they haven't grown up around it, or perhaps too, there's a concentrator in the room and it's kind of noisy, or they don't have their hearing aids in. And so this comment comes up a lot, I think, because we just have a diverse group of people who work here and everybody doesn't necessarily sound the same. So I always try to say, well, everybody here speaks English, and sometimes it goes different directions.
So tell me, what has been the reaction before taking care of that person? Like, if you know it, if these things, I don't think people often appreciate how it spreads amongst the staff, that that person is what we would call difficult, or may have certain biases. How do you then get the staff, the nurses and the CNAs to still, go into the room? What has happened? Like, how do you have those conversations?
So a lot of times they actually come to my social worker, and I'm witness to this because I'm here all the time. A lot of times they come to the social worker, or, maybe I'll hear it at the desk, or I happen to be talking to them or something like that. And they'll say, well, I don't want to go back in that room because patient so-and-so, said this about me, or XYZ. But kind of in my overhearing it with the social worker, or being there with the social worker, we kind of have the initial conversation. We say, this patient, may not be used to it. It doesn't make it okay. We try to support the staff and say, this is not okay. We know it's not okay. And sometimes we might even go talk to the patient. Sometimes my social worker goes and says, hey, we have a lot of different people who work here. What you said is not appropriate. And they say it in a very lovely way because my social workers are magical and they just know how to talk to people. And we might say, everybody here speaks English, is it that you're having a hard time hearing, or is it something else? Or they might say, well, I just can't hear because you have a mask on, or this or that. And we kind of talk to the staff in a way that says, we may not be able to change the patient's behavior. We may not be able to change what they see about you, but we tell them, we try to validate their feelings for sure. We say, we know it's not okay. It's not okay. And there's these lines of, when do you ask the management to say, from a management company perspective of, look, so-and-so, you cannot behave this way with staff, versus the more subtle things that they say all the time. Really, finally someone who speaks English, it happens so much. The staff, a lot of them, what they tell me is that, Brett, it happens so much, I'm just used to it. And they just kind of brush it over, and they keep taking care of the patient. And they're really amazing because they work so hard. And, I have CNA care partners who they may not understand the background of the patient, and the patient may not understand the background of them, but they continue to work hard because they want to take care of people. They say, I'm here because I want to take care of people. I want to make sure this person gets what they need. And so we try to support them and step in if we need to. But I think deep down too, we know that probably that person is not going to completely change the way they behave or feel in their short time with us. And so I don't have like a great 1, 2, 3 step answer of like how to fix it. But those are some of the things that I've seen our staff go through.
Yeah, and I don't think there is a 1, 2, 3 fix it. Dr. Hawk, you have your hand up. Go ahead. Unmute yourself, please. We can hear you now.
Very interesting talk. And I think, Brett, what you just said, if we may call you Brett.
Sure.
The staff works there because, one, they make a living there, but two, and I think for many of us, because they do good work for the right reason to other human beings. All of us in my career, which is long, we've had difficult behavior patients that call out, resist care. They're sick, they don't feel well, they're chronically ill in long-term care. They don't have much filter when they talk to any of us. I've been called names, I've been hit, I've been slugged. But I'm trying to understand where the discrimination is, where it's what happens in long-term care with people, no matter, I guess this is in the intellect of the beholder. I think it's because they're irritable or sick or have cognitive deficits or no social filter, but they've said the very same thing to me. And I look like them or I don't look like them. So where is the discrimination in bad behavior? Now, I get it. If they start using racial epithets and start screaming stuff like that, I get it. And of course, we would say, look, this is your caregiver. You either get this person to take care of you, and I've done this twice in my career, or you get no one to take care of you. And one fellow decided on no one, and for a whole day, he got no care. And he decided that his caregiver, whatever they look like, was pretty good.
Well, and Dr. Hawk and Brett, you can let me know if you agree. I think there is a component of perception and perspective that we have to consider, because everyone goes into every interaction with their own biases, their own way of hearing things and listening to things. And in thinking of a situation where it may not sound offensive for someone to say, oh yeah, you finally, I get someone in here who speaks English. But that could be the one offensive thing that person who's receiving that is hearing. That could be they're hearing something that's offensive because it requires you to have made a judgment on maybe the way they're speaking, the way that they appear. Sometimes and often in South Florida, it may require you to think that everyone who is of a certain race, they only speak this language, or everyone who is Latino has a heavy accent and you're not going to be able to understand them. And I've seen it go in a lot of different ways where there is times where people are just, you don't know how to take it. You're like, okay, are you just happy because you were having trouble understanding someone? Or is this something being said that's offensive? And it really comes down to how that person is perceiving it. And I think that what we have to do in this moment is really be sensitive to the fact that some of the things that we've probably normally considered can be construed as being offensive to another person. And I don't know, Brette, what you would think.
Oh, sure, absolutely. I mean, there's so many different ways to talk about it. I mean, to be honest, I didn't used to really think about it until, I started working more in the environment, and I heard it because I didn't hear it before. And then when I heard it so much and I had to think about it, now it's something that of course I do think about more and more often. And I think when I try to put myself in the shoes of someone who works here, and I think if someone's saying things like that to me every single day, what does that mean for me, Brette, when I know that maybe my CNA Jane over here hears this every single day, maybe from more than one person. It's just, for me, it's something to just learn from and say, okay, maybe this is something that, like, I need to think about. Maybe I've said something like this to somebody, or maybe I need to speak up more when I hear that, because I used to just laugh that off. I did not used to say anything to the patients. I would say, we just have a job to do. Just do your job, put your head down and do the work. But when I started hearing it more, and when I see how it affects the people that I work with, and the people that, honestly, once I have more of a relationship with them, their pain is more real to me, or their discomfort is more real to me. And I think, okay, wow, like, maybe I don't have that same discomfort, but I see that they're going through something very difficult, and I care about them now. Is there something else I could be doing to somehow, if not change the way things are, somehow let that person know who I care about, like, that I support them. And so now I will say something like, well, Mr. Anderson, everybody does speak English here, or something lots along those lines, when I used to not say anything before. And that's only a very small change. And I'm like, I don't think that I've made the world turn another direction by making that small change. But I will say that I did not used to think about those things before the way I think about them now. And I try to think too, just what are my own biases and prejudices, because I know I have them, and I may not share them here on this call because you all don't know me, and I don't want you to know the evil things that have gone through my head probably in the past. But it has helped me start to recognize those things too. Like, if my initial reaction is one thing, sometimes I have to think, like, why am I reacting that way? Is it just because, like, what's the reason for my reaction? And maybe it's a righteous reason, or maybe I'm, am I mad for some other reason, or am I not reacting and maybe I should be reacting? Like, I might hear, we have had patients call our staff the N-word many, many times. And it's kind of like, if I'm not reacting to that, I probably should be, like, that's kind of the level of, you do not do that. And I feel like that's like a very, very unacceptable behavior, from anyone. I mean, I know we'll get to the question about people living with dementia, Diane, which is going to be a whole nother thing. But
yeah,
that's
I just want to interject,
yeah.
Not to cut you off, Brette. I would just interject. Think about those situations where you have maybe that nurse who you clearly understand, and that is the person who is the go-to on that unit or in that building. And if they are receiving someone who they feel is discriminating against them because of their accent or their skin color, and I would just share, I had a nurse, she was of Jamaican descent from England. She spoke the Queen's English, and someone couldn't understand her accent. And I think you really have to think about the way that information is coming back to people, because there is some layering to that. Maybe not in every situation, but I think as we're moving through our facilities and working with our teams, we have to listen and really think about what's the cumulative effect of hearing these kind of things every day. And Dr. Hawk, I know you have your hand up again. And we could definitely take your comment before moving to the next case.
Well, none of us want to hear insults of any kind, but I think we are a bit more forgiving in our space of long-term care because these people are in a facility. They often are quite ill. They have cognitive deficits and physical debilities that make them irritable, but we don't want to hear any insults. And actually, in some facilities and even hospitals, some of the staff do not speak English, but they're still wonderful caregivers, and we use interpreters when needed to do that. Where is the disparity of care when we hear insults or when someone really doesn't speak English, which I think is okay?
Yeah. I think the disparity comes in how does that staff member or even that patient, depending on the flow of those comments, how do they then respond when there's an issue? Are they going to trust you to share that information? And I think I could use myself as an example for unfortunately way too many things. But there are times when you're the patient and you're sitting with your physician and you don't feel heard. And I go through like the ABCs, like, okay, is this because I'm a woman? Is this because I'm a Black woman? Is this because of all of the above when you're in that situation? And when you are not able to, in my opinion, where you're not able to establish a trusting relationship, it does impact care. What does it get said when I don't know how that person is, if they're going to take my information? What does it get asked if you're the clinician and somebody just sort of hits you with that? Does that throw you off of the questions that you're going to then ask? Are you like trying to circle back to, okay, there was something I needed to address with you, but now I can't get the fact that you're trying to this accent and you're saying that I don't speak English well. I don't know what's on the other end of that, but I do worry about that. And Dr. Pandya put a good comment into the chat that modeling good interpersonal interactions and respect to the staff in front of patients helps. I do definitely agree, Dr. Pandya. I don't know if you want to talk more to that, but that's that emotional intelligence piece that I always go back to. You have to learn how to communicate with each other, and being a good role model is helpful. Dr. Pandya, I don't know if you want to share.
That's just a minute, Dr. Sanders. Thanks. That's a really great discussion. But I just find instinctively that if you don't cut it right away and counteract bad behavior with positive behavior, if you're there and you're seeing that, then you've lost an opportunity. And then I think a lot of our work in long-term care, whether it's modeling good communication, patient assessment, it's all done by role modeling and training, moments of micro teaching to try and move the needle in our setting. And so I just feel if you're there, you might even want to say, as Dr. Svensson said, something directly to the patient, but actually showing that you respect and trust the caregiver, that there have been disparity. And just to answer a case of, I don't want to see that clinician, since you have it. When I was a new attending after my fellowship in Detroit, we had a consult service asked to see a very aristocratic lady who saw myself, and our fellow was Sudanese, a geriatrics fellow, and I was the attending. So we roll up, to the bedside, all eager and smiling. And but the daughter said she didn't want to see us because she, had a very high, lineage and roots, and she would feel offended. So we just politely left and talked to the chief of the department at that time, and he immediately, and I'll always respect him for that, he called the family or the daughter who was at the bedside, and he said we were part of the department, everybody was well trained and he had equal confidence, and we were the team on call. So it was either we saw the patient or nobody saw the patient. And a few minutes later, we were up there doing the consult. So thank you.
I think, Dr.
Thank you
Pandya,
for
I think
sharing that. That's great. Yeah.
Yeah,
I'll always respect him for that. He kind of stood them down.
I think that's an example that we hope we've all seen in our careers, where they are part of the team and they are part of the team that will take care of you. And
Yeah.
Dr. Sanders, I think your answer to my question about what's behind the comments that they make or how they say it is very appropriate. That was a great answer to my comment. Thank you.
Thank you. It is great to have your heroes on. So Dr. Pandya and Dr. Hawk, this is amazing. So I wanted to share a case that Dr. Fatima Nadvik shared with us about not having a patient state, I don't want to see that clinician. And I thank you, Dr. Pandya, for the case that for that real example that you just gave us. In this case, this patient saw that the clinician came in with the hijab, the headdress, and they just made a decision that they didn't want to see that person. And the question that I wanted to discuss is what happens when that discrimination is towards the clinician in a very apparent way. And Brette, I'll start with you, like in thinking about that. And if there's ever been a situation where that has happened to you, please, if you're willing, go ahead and share it.
Sure, let me think for a second. On a personal level, I mean, I can't think off the top of my head where I don't think somebody did not want to see me because of looking Asian. I mean, I've had them assume that I was going to have a strong accent or assume something else, I do get sometimes that they don't want to see me because I'm not the doctor. I get it on that level, a lot. And I personally don't take offense on that level because I know a lot of my patients are used to seeing their primary care doctor or their cardiologist or whoever, and they see them for their whole life. And then they come here and they say, well, you're not the doctor. I mean, I don't want to see you. Unfortunately for them here, I'm the only one here today. So I said, well, you can talk to me or you can wait for the doctor. She might be in on Saturday. And usually they talk to me. On the I don't want to see the clinician case, I know that I have a very close friend who actually my medical director, she has a family medicine outpatient clinic. She takes a lot of medical residents and a lot of medical students. And I know this happened to one of her medical students. She came in with her hair covered, and the patient was, I forget his ethnic background or what race he identified with. But the patient, said, well, I just made a snap decision. I don't want to see this person because of what they assumed. I think in that situation, of course, the student was respectful and she left and she told the doctor or she told whoever was kind of attending with her that day. And I think they went in with someone else. I wish I could remember though if they talked to that patient or not. Unfortunately, I should have asked her before I logged on today. How did that actually turn out? That was a situation where sure there was someone else who could see the patient, but it's I don't know, it's hard. It's hard because she was
very hard. Yeah, it's very hard, and I wish in the situations that I had, I wish someone was as brave as to do what they did for Dr. Pandya when you were in that situation, Dr. Pandya. But I know I've seen us become very accommodating to the patient, and we once found a different person to go in there and do the examination. But then there are times, and especially in the post-acute long-term care space, there are times when you are the person. And I've had people who said they didn't want to see me. First, some people didn't know that I was the doctor, so that's one thing. And it was, I guess, very surprising that I was the doctor in certain situations. But others felt that, well, they couldn't relate to me and they would prefer someone else or somebody else. And I've had facilities be very accommodating to the patient, and you get that patient transferred to another person's service. And I think that it's something that we really should discuss and think about, how should we be addressing those situations? I prefer when you explain to the patient where I am the clinician. I am here to see you. I need to do my examination. And if you want to then find another clinician, that's fine. Something like that, where you really respond directly. Those are the things I've done in the past. But they're just, it really comes down to the facility at times, how accommodating they're going to be towards that patient in that moment.
May I ask again?
Mm-hmm.
So if you look at our attendees here, I'm the guy who looks like the majority guy, old white guy losing hair. But I will tell you, your experiences I share with you. I've had families and residents say, "You're not my doctor, so I don't want to see you." Or, so all of us have had, so those are our experiences. I absolutely understand that you may have experienced that more or more deeply or more intensely. But do you think that we have, from the high level medical staff, the DNPs, physicians, nurse practitioners, DONs, do you think we have a built-in bias against our residents about how they look or sound or behave that changes the kind of care they get? Ultimately, I can process however they insult me or slander me or talk to me. I can either leave or I can accept it. I can do my work. I can be angry. I can forget it. But what kind of care do they get based on us?
Yeah, that's a great question. And I think that there are a lot of biases that we as clinicians have built in. And like I said, you bring everything in. So you brought everything that you may have learned from your previous experiences and some of those other biases into that situation. And it really actually brings me to this next. Who had multiple conditions. And please let me know if you guys can still see me. I don't know if I just froze for a minute, but they had multiple conditions where they had atrial fibrillation, poorly controlled diabetes, advanced coronary artery disease, status post 3, stents being placed, and the facility physician who the patient was originally assigned to had those conversations about palliative care and transitioning to hospice. And she had been hospitalized multiple times. They were having the conversations in the hospital with the daughter. And it came to a point where the conversation really had to evolve, and we had to really figure out what was going on. And the daughter said to me, she's like, "Sorry, doctor, I don't understand." And it really came down to her not understanding, not what was being said to her in the way that it was being said to her. She stated, I received multiple hospice pamphlets. I have received multiple, I had multiple conversations with people telling me that my mother isn't doing well, but my mother doesn't understand, and I don't understand, what does that mean? And I thought of it as more of a case of health literacy, where we're throwing all this information at a person in a manner that, yes, they could take a pamphlet, but in a manner that they may not understand, because no one was simply telling them that another stent wouldn't change your mother's condition, another hospitalization. There's no other interventions that are going to impact her condition, and it's really down to becoming a quality of life. But nobody has had that conversation. What they did state, if you review the records, is that the family wants to do everything. They don't want to have this conversation. You know, a lot of statements about the daughter being difficult and not understanding, even down to what the facility was writing. And I think that we need to really think about the way we're communicating with people, and some of the pushback that we may receive from them may not be because they're being obstinate or they are just disagreeing with our treatment plan. Maybe it's down to the point where they don't really understand what that means, and they have that barrier, and our own biases are getting in the way of us communicating further with them. I didn't mention that this was a African-American family, and the mother had graduated from high school, and the daughter, she had high school, but that she had graduated from high school, but that was the extent of her education. And they just didn't understand the pamphlets and the handouts that they were receiving. And most of the conversations that they had around advanced care planning was a handout when it really came down to it, and try to break it down to them.
Yeah, Diane.
So I know we're oh, go ahead, Brette.
Oh, sorry, I was just saying, as you were going through that, I was thinking of all these situations currently where actually I was like, oh my gosh, I am so guilty of assuming, because to be totally honest, I mean, even just recently, either getting someone back from the hospital or getting a new patient, and I'm looking at the paperwork I have, and when I see that maybe the palliative team has talked to them, and you know, it's someone older, it's your classic older patient living with dementia, who for us in the nursing home, you know, we get so used to this patient population. Whenever somebody who's let's say 95, living with dementia, failure to thrive, just got a new peg tube, we all kind of internally roll our eyes, and we're like, oh no, here comes another one, like, oh, and a full code. And I think that, to be very honest with everyone on this video call right now, I make a lot of assumptions about, oh gosh, this family is going to be so hard to talk to, or oh gosh, I don't even want to try. And I realize that's really not fair, you know. And I don't know anything about this family, and I don't know a lot about this patient, but my 93-year-old grandmother like wants to be a full code, and I have to be okay with that, you know. And so I find that personally, I'm not okay if they're not a DNR, but I have to be okay with understanding who this patient is and what they mean to their family and what's going on in their family, and maybe even what's their background, because it's probably different from me, and not assume that, well, they're just not a DNR because they just don't know anything. Oh, they're not a DNR because they're in denial, you know. And maybe there is denial, but that's the classic reaction that I have had a lot, to be very, very honest, is, oh gosh, here comes another one. They must be in denial. Oh, it's going to be so hard to work with these people. And, you know, maybe it is, or maybe it isn't. But that's what I just thought about in my head. And I had a little fast heartbeat because I said, oh my gosh, that's me.
Well, I think it is probably a lot of us. I think that and I thank you for sharing that and being so open. I think that it is hard to, you know, when you say, okay, do you want to be a full code? And someone's like, oh, yeah, you know, I don't want to be denied a treatment because I've been denied so many things in my lifetime. Why would you deny me a treatment that you're going to give to everyone else? And you really have to, you know, you have to approach that conversation so differently, thinking about the person's perspective, their background, their ethnicity, their race, the experiences they may have had. It's not always easy. And for me, it's not always the one conversation. It may be multiple conversations over days, or even that same day, where I am learning what that person values, depending on how much time you have. You know, different when I used to round in hospitals, but you would sit down and figure out what they loved and what they valued. And I would not ask to do not resuscitate. I would ask, okay, if your mother's heart stopped, Would you want us to do chest compressions? Would you want us to do that? You know, those kind of things. And honestly, I know I'm always guilty of oversharing, but I even have those conversations within my own family where I have to walk them through what the process is when it comes to what that means about do not resuscitate. Yes, Dr. Hawk.
So I think, Brett, we all make exactly the same assessment and assumption that you do. You know, here comes a full code PEG tube, tray, chronic aspirator, all of that. And I think you make such a good point. And Diane, when we see people come in that are of African American or island African or Hispanic background, we're quick to make those assumptions. And that's when I think racial disparity does matter. But most of us, and I'll guarantee you, Brett and Dr. Sanders, that you're quick on your feet. That assumption you're very quick to dismiss as soon as you start to engage that resident, that patient and family, because you want the path of care to be the path of care they would want based on their culture, the belief system. And for me, in palliative care, if I make an assumption about somebody from Cuba, I stop that assumption and I ask them, how do you feel about this? How do you feel? What's your belief system? What's important to you? So that we, I hope, attempt to remove our embedded stereotypes so we can give them the kind of care that they're asking for, that they want as an informed patient. Sorry to go on about that, but I think we live in the very same world you do, and we do our very best to think about diminishing disparities based on background.
Yeah, and I think that I would say it took a long time to kill the thought of this patient is a train wreck from my head, like to remove that language, because it was reinforced going through residency, and then actually after fellowship, you know, that was like the bright spot where you're learning more about how to have these conversations. But then once you're out in practice, it gets reinforced again. It's like, okay, this is a train wreck. This is a train wreck. And I had to unlearn that so that I could have those conversations. And, you know, I know we're running short of time, but I really want to talk about how do we deal with our patients who have dementia, who may use racial slurs. And, you know, we've had, and there are so many cases where it comes, the one that I think of is one in which you overhear the patient using certain languages, like you said, Brett, earlier, the N-word towards their CNA who's trying to provide them care. What should be the approach to this patient and the staff who cares for him or her? And Brett, you know, I'll let you get the first response.
Sure. I know I've talked about this with my social worker a lot, actually, because we do see it happen. And, you know, one of the things she has taught me is that, you know, you look at this person, you know, you look at them, you know, not just dementia patient or not just person who called me a terrible name, but she said, you know, when you look at these people, your patients, they're with their cognitive impairment, whatever it may be from, she said, you know, they may be people who, until that happened to their brain, they would have never said something like this. She said they could have been people who would have been mortified or not been like this at all until the dementia progressed or the Parkinson's disease progressed or something. And then that filter, I think Dr. Hawk mentioned this earlier, the filter is not there. You know, I mean, they have a disease that is affecting their brain that they cannot stop or help. And maybe they would have never done this in the first place, but now they're in a place where, you know, maybe that it's probably could have been something they grew up with, but they never said that because they knew it was wrong. Or maybe, you know, or maybe that wasn't the whole time. I don't know. You know, that one piece of advice has been helpful to think like, you know, just for me, it's like, okay, just my initial reaction is usually shock and I'm angry, but it's also, okay, you know, maybe this really isn't them. This isn't who they are. And I can kind of hold my assumptions so that I can take care of this person. And sometimes it's happened and we've talked to people's families about it, and the families are completely mortified. They say, oh my gosh. We had a gentleman years ago, I'll tell this story quickly. We had a gentleman years ago who had been a pastor his whole life. And then his dementia progressed quite rapidly and he came to live with us. And he said things that you just never thought a pastor would say. And his family, his wife, was just absolutely mortified and just embarrassed the whole time, because she said, this is not my husband. He doesn't say these things. He doesn't act like this. This is not what he believes. And so that was helpful to hear too, because it helped me think, no, this isn't your husband. This isn't who you've been married to for 45 years, but this thing is happening to his brain. And, I could get over, I don't know that he really means it. I know some of the staff were like, oh, Brette, he means it, and it's, again, I don't know the right answer, but knowing that that person had said like this, there's just no way. Oh my gosh, I've never heard mom talk like that. Or I'm just so embarrassed for my mom, but you can't really stop this particular type of patient. But that advice has helped me a little bit, if it's helpful at all for anyone else.
No, I think that's some very great advice. I know, Pam, you have your hand up.
I do. Thank you, Dr. Sanders-Cepeda. I was a little shy about talking about this kind of stuff because I feel like so much of it has become a political platform and has gone in good directions and in not good directions. But I wanted to say something about this particular slide. My grandmother, I'm a Southern girl, brought up in the Deep South in Louisiana, and my grandmother and my mother made sure that I did not use, and I was taught from a child to be respectful of all of our community. And I mean the Blacks, the whites, and we were Black and white. And I was taught by these powerful women to be respectful. My grandmother goes into a nursing home at 96 years old with moderate dementia, and it goes to severe dementia, and I hear her say the N-word. She would never, ever have done that. She taught me not to, in an era when that wasn't taught to the young people. And I admired her as I grew up so much for this. So this means so much for you to understand and realize it's not even what they were taught. It's just something that comes out from a bizarre place, and it's really not meaningful when they're this deep into the dementia. So thank you for that, Brette.
Oh, thank you, Pam. Oh my goodness.
You're gonna make us all cry, Pam. Yeah. I think that it's important when you hear this, and there are certain things you may not be able to ever teach that person with dementia to not say. I think it really comes down to how we go back to supporting the staff member who may be hearing that, because as I said before, these things are cumulative. And even if it may not bother you the first time you hear it, or the second or the third, you may not be having the very best day or that 50th time that this happens. So we just need to be mindful that, that even if it's not something that is being intentionally hurtful, that it can still cause pain amongst our staff. And I think if we approach it that way, in thinking about who is the recipient of those words, maybe that will help. And I know you Pam, you brought up like the political climate, and I've shied away from talking about this for so long until this past year, I think, where it felt like I couldn't escape it. And I know that some people feel that, that this is really political, and maybe so, unless you're living with it as an everyday concern. I don't know. I can't really separate. I don't really see it as something that should be debated amongst politicians when it's like the everyday, where you're trying to figure out what do you share and tell your family members and your kids, and how to behave so that that nothing horrid happens to them. And Brett, I know you and I in closing, maybe you could share what you shared with me about, the situation after those tragic killings in Georgia, how that made you feel.
Sure. For those of you not privy to Diane and mine's conversation yesterday, I was telling Diane about how when a couple months ago, actually, I think it was a couple months ago, a little more than a month ago, the Atlanta spa shootings occurred. And if you're not familiar with the situation, a young man went on a killing spree, shooting, I want to say three Atlanta spa locations, one up a little north of me, and then drove to kind of in the Atlanta, maybe Midtown area or Buckhead or something. And the majority of the victims were of an Asian background. There were a couple who were not, but the majority were of an Asian background. And it was shocking. I mean, honestly, when it first came out, I didn't really think too much of it, because as sad as it is on the news every day in Atlanta, there's a lot of shooting stories and you kind of get just desensitized to it. But then as it kind of took hype over the next 48 hours, we saw the response of just the media. I didn't tell you all of this, Diane, because I know we were talking quickly, but I saw the response of the media that as soon as it came out, they showed the picture of this young man's face, and they were talking about understanding this young man and what would drive him to do such a thing, and what is his background. And they were interviewing people that he used to know in church and things like that. And then we saw the response of the police department spokesperson, who I think, just very poor choice of words, he happened to say this man was having a very bad day and this is what happened. And of course, a lot of people were upset. The other communities besides the Asian American community were kind of outraged. And as I started thinking about it more, I got very upset and I kind of got scared. And it was a couple weeks of kind of reconciling, like, how I felt about this person who did this. And it was kind of in an area really close to home. And I kind of had to think through it. And I had gone to the grocery store the next day and I thought, what if somebody comes in here? What if somebody comes into a place, where I'm going and wants to do that? Because I thought, well, gosh, this could happen anywhere, anytime. And I was scared for a little bit. And then I realized, you can't be scared to go do your regular life. But it just affected me in a way where I sat back all of a sudden and I thought, oh my goodness. I said, there are people who feel like this every day of their life, or have felt like this to an even higher degree every day of their entire life. And I thought about John Lewis, our recently passed congressman here in Georgia, because I had been reading his memoir last year, where he talked about kind of the things that he endured, and how at the time I thought, I am so glad that racism doesn't show itself like this anymore. And then I thought, but does it still do that, just in different ways? And is there anything that I can do? And kind of, I know Dr. Hawk mentioned, like, stopping our assumptions in my everyday life, whether it's here in my job every day or in other areas of my life, where is there something else I can be doing to stop my own assumptions? But the way the spa shootings made me feel was just really eye-opening, because I thought other people feel this way in a much worse way. And so I, in some ways, I mean, I'm not really thankful for the way I feel, but I guess in some ways I kind of am, because it's helped me connect a little bit better to some of my other coworkers here at the job, and also in other areas of life. And so that was kind of just my thoughts that I was sharing with Diane yesterday.
Thank you for sharing that. And I know we're at time, guys, and it feels like we could probably talk for like hours more. Dr. Padilla did highlight that in JAMDA, in the May issue, there is a great article, and there is a great article on systemic racism and long-term care by Dr. Sloan and company, and it is really a great read. Thank you everyone who either shared something directly into the chat or raised your hand and spoke. Thank you, Brett, for being so open. And I will say, yeah, when you live it is something that we are all living. And I think that we need to keep taking moments to reflect about where we're at and where we're going. With that, have a great day, everyone.